Good afternoon, everybody. We'll start and let everybody join while I'm presenting the introduction. So welcome all to the Quality and Safety Network. This is our 10th webinar. I hope it will be interesting and be able to share best practices and experiences like we always do, so we can effectively learn from each other and improve quality of care and patient safety in our countries. Since 2019, we've had a lot of webinars. You can see here most of the topics. As you know, or for the new people connecting who don't know, all of these webinars have been recorded and are available on YouTube, and every PowerPoint presentation is also available on our website. And we're ending 2021 with a last webinar on patient-reported incidents, a pilot project organized by PACS, which will be presented by qu'on. Just so you know, today we have a lot of countries represented all over Europe. Also, some people from India registered, from Tunis. So it's interesting to see that we're going beyond Europe. So that's all for me. I'll be letting my colleague Quentin take the floor and present to you what work has been done in Belgium around patient-reported incident measures.
Okay, hi everyone. I'm going to share my screen. You see my screen? No?
Yes.
Okay. Hello, everyone. I'm Ripet. In this presentation, I'm going to speak about a pilot project here in PACS, in progress, actually, on the measure of patient experience about safety issues. But before starting, I'm going to introduce myself. My name is Quentin Sconvar, and I'm Data and Improvement Officer at PACS. My initial formation is demographer, and I'm a specialist in, and I have an expertise in quantitative analysis of population dynamics. And at PACS, I work essentially on all projects related to quality indicators and also on analysis method, specific analysis method for quality indicators. Okay, just a slide to remember the acronym of PACS and our mission. We are a platform for continuous improvement, for quality of care and patient safety, and you can read our mission on this slide. Now I'm going to introduce this presentation with some data. I would like to come back with you to a survey conducted among European citizens and Belgian citizens specifically. This survey is a neurobarometer, and she gives an indication of how the Belgian population and European population perceive quality of care and patient safety. We have two Eurobarometers, a first one in 2009 and a second one in 2013. These Eurobarometers assess 4 topics. The first is whether your citizens are well informed about patient safety measures. The second is the likelihood of experiences an adverse event and the circumstances and characteristics of this experience. A third topic is the type of redress available if citizens suffer an adverse event and where they can turn for help. And finally, the EU public perception of the quality of care. We can have this perception with these two Eurobarometers, these two surveys. And what can we learn with the data of these surveys? Sorry for other countries, but the Belgian population have the most positive assessment of the quality of care in Europe. you can see 97% of Belgians believe that the quality of care provided are good or very good in Belgium. We are the first one in Belgium, in Europe. And if you see, this proportion varies from one country to another country. You can see, for example, in Romania, this proportion is only 25%, and 71% of European citizens give a positive assessment of the quality of care in their country. Belgium is the best evaluation. In Belgium, we have the best evaluation. But it's a good news, but we have also other results, and we can see that 49% of Belgian respondents think they could be harmed by hospital care. It's a little paradox, because you see we have good quality of care, but when you ask to people if they can harm, they say yes. Half of the population respond yes, we could be harmed by hospital care. And if we dig a little bit the result, we can see that 27% of Belgian citizens say that they themselves or a member of the family had experienced an adverse event during their hospital care. It's the paradox, I say. We have in Belgium the most paradoxal situation, because we observe the higher gap between the bad quality and the risk to be harmed by hospital care. The question here is why respondents say that the quality of care is good, while the healthcare system can be hurt patients. It's the paradox, and we are going to try to bring a response to this question. In fact, there is maybe an explanation. Just remember, according to the World Health Organization definition, safety of care is one of the 6 dimensions of quality of care. But if you ask to Belgian population, patient safety is not seen as a priority when they are assessing the quality of care, because they say it was we have good quality of care in Belgium, but we can be hurt by care. The hypothesis we have, an hypothesis is that patients believe that they can trust the healthcare system in managing the patient safety issue. And our healthcare systems are able to provide themselves safe care, and therefore patients should not assume a role in their own safety. And it's why we can observe this kind of paradoxal situation in the data of the survey, European survey, we can see. This hypothesis is not unfounded. For example, last month, during a congress on Never event, held by a Swiss Patient Safety Foundation, speaker explained some patient perception about this serious adverse event. For example, patients feel that authorities and healthcare organizations are doing everything to best manage the adverse event. Yes, and patient thinks that all the mechanisms are in place to manage this adverse event. At the same time, these patients are convinced that everything is done in hospital to manage these serious adverse events also. The authorities and the hospitals are good to manage this adverse event. But many hospitals are not well prepared to manage at best these never events. It's a conclusion made by the foundation, the Swiss Patient Safety Foundation, in an article they published recently. And you see that there is a perception about about the good management of adverse event, but we know that the system and also the organization are not well prepared to manage at best these never events. In fact, there is a need to inform, I think, there is a need to inform and raise awareness of patient safety among stakeholders in healthcare systems. It's the conclusion we can have about this observation and this perception we have in our healthcare systems. The question, finally, is the patient experience is an approach to improve patient safety? And I'm going to try to bring a response to this question. But before, I want to come back on the definition of patient experience and what does it mean really. You can read the definition of Beryl Institute. The patient experience is the sum of all interaction shaped by an organization culture that influence patient perceptions across the continuum of care. This definition tells us that the patient have interaction with the healthcare systems, and this interaction generate risk for patients who can give their perception about this risk. And it's a fact we can ask to the patient if they can see risk or also incident during their interaction with the healthcare system or with an organization. If we look the relation between patient experience and patient safety in the literature, we can see some correlation. I speak about correlation and not causality, because there is a correlation. You will see. I'm going to explain the correlation, but what we see, it's in the literature, there is a positive association, in fact, between patient experience and safety issues. Sometimes there is a lack of association, but you can explain this lack of association in the studies with specific factors. But some studies show that, for example, the patient safety indicators are correlated to the patient experience. The safety culture is correlated to the patient experience. Complications are correlated to the patient experience. And you can see that there is a positive, when there is a positive patient experience, there is less incident or a better safety culture. And you can see this relation in literature. How can we explain finally this correlation? Firstly, it's logical, but if a patient experiment an adverse event in this situation, it will give a negative impact. This situation, sorry, will give a negative impact on its experience, on the patient experience. It's the first relation you have between patient safety and patient experience. But on the other side, you can have a correlation in this way. For example, if you give to a patient good information or about, for example, continuity of treatment, about risk on hand hygiene or risk on medication error, this good information empowers patient about safety issues, and you can reduce the risk to have an incident or harm in the system. And you see in this situation, there is a correlation, but not a causality. It's it's a circle, and the experience, patient experience, is correlated to patient safety. And I'm going to speak about message or message we can give to patient to reduce risk. And we have also this kind of message in our daily life in many sectors. For example, in aviation, for the safety road, or for health prevention message. For the alcohol abuse, you have also a message to reduce risk. We can inform patient or population to reduce some risk in some sectors. And we can do the same thing in the healthcare system. with some methods, but one of these methods, it's to collect data. It's to collect data and to ask the patient if they are aware about this problematic of safety. This problematic of safety issues. For example, in Belgium, we have concrete example in Belgium. We have already seen in the 7th nationwide hand hygiene campaign with patients as target population in this campaign. This campaign focused on involving patients, their family, and hospital management. The message was all together, let's avoid infection. And in this campaign, patient involvement was stimulated with promotional material, but with a specific survey and specific question about safety issues. For example, you can see an example of question in this survey, and we asked the patient if in the past 24 hours they have seen a caregiver disinfect their hands, and you can see that 3/4 of patients say yes, 7% say no, 2.5% were not sure, and 10% did not pay attention. You can see in this data, in this first example, you can see the capacity for patients to identify risk behavior that they could lead to an incident, because if you respond no, you can identify this risk to have a nosocomial infection in hospital. A second question, a second example in this survey, we asked the patient, what are you doing if you see a caregiver has not cleaned their hand before touching you? And here you can see also that 27% told directly to the caregiver. Some talk to another professional, or 5% to a family member or visitor. But the results, the main results here, it's 39% do nothing when they see a caregiver has not cleaned their hand before touching a patient. And this result showed that we can improve speak-up behavior with patient. We can say to patient, if you see someone who don't clean their hand before touching you, you can say something to have a reaction or an adaptation of the behavior of the caregiver behavior. And we can see here there is a potential improvement in this area. In fact, we see that there is a benefit for patients when we inform them, when we inform patients about safety issues and management of incidents when they occur. We can improve the knowledge of patients, and we can after stimulate the speak-up behaviors to reduce risk and improve patient safety, in fact. And we see here that the patient can be actors of their own safety when we stimulate their knowledge about this issue. Now I'm going to present, after this introduction, I'm going to present a specific project we are in Belgium to promote the use of PRIM in Belgium and in our healthcare system. First of all, I would like to show this this figure. It's a figure from the report Measuring Patient Safety, Opening the Black Box. It's an OECD report. In this report, we can see that our healthcare systems have 3 types of data sources. The first type of sources is the adverse event reporting by caregivers. In fact, the integrity of adverse event reporting system really partly on incident disclosures and relate process of in-depth analysis and learning. We know that this source is not exhaustive, and many factors such safety culture in an organization has an impact on the declaration of adverse event, but it's a first photography of the situation in a system. It's the adverse event reporting by caregivers. The second source are routinely collected data. These data are collected for other purposes, such as funding or system management, but these data nevertheless capture harm also. Routine data include the medical records, which can be a rich source of information on safety problems. Probably you know one of the best example of this kind of data. It's the patient safety indicators, the PSE. It's a good example of indicators construct on routinely collected data. So it's the second source of information. And the third source of information are the patient-reported measure. Patients have a unique and valuable perception of on healthcare process when things do not go to plan and when they do. Information gathered from patients about their care is important for learning in improvement tools like adverse event reporting and routinely data collected. With these three, you can see these three data sources are connected. Some data sources can detect all the same adverse event, but you can see that the circle are can be just only you have only one. You can just, for example, detect an adverse event by a patient, and you can detect you can't detect this adverse event with other sources. It's why we have to combine the three data sources in our measurement system of adverse event. There is also in literature, we can also see a relationship between incidents reported by patient and those identified by the system. You can see these figures from an article. You have the sources here, but what can we learn? In this article, 35% of patient-reported incidents were classified by clinicians as safety incidents. There is a correlation between the two type of data source. Another study show also patient-reported incidents are strongly correlated with adverse events detected with a global trigger tool method. There is also a correlation in this study. In the figure here, you can also see that the medication issues or medication error are the type of incident with the stronger correlation. You find when a patient say there is a problem with the medication issues, the clinician identify also this incident in the patient files, in fact. We have now one tool to present to detect to active the patient voice in the detection of incident and the management of incidents. It's the patient reported incident measure, or PRIM. We say PRIM in general. It's the acronym of this type of tool. It's typically a survey on the patient experience, but specific to the incident measurement. In 2019, in fact, PACS integrate a working group on patient-reported safety indicators in the OECD. The objective of this group is to develop a small set of indicators which measure important aspects of patient safety in hospital care for international reporting. Who participate to this working group? You have 14 countries, and you can see the countries here. There is Belgium, France, Germany, Sweden, United Kingdom, Portugal, Poland, Slovenia, and so on. You have also the European Patient Forums in these working groups and the Commonwealth Fund, two organizations with their expertise to who are here to help the group to identify a specific tool. The timing of the project was like that. The OECD started the indicator selection in March to June 2019. How they do that? They make a review of national and international survey with a specific question about safety issues. OECD survey of experts and patient representatives try to identify priority indicators. This evaluation about priorities were based on 4 assessment criteria. The first one is the clinical importance and relevance to provider practice. The second one, the policy importance and relevance to health policy. The third one, the importance to patient. And the fourth, the feasibility of data collection. The patient representative and expert evaluate the question based on the 4 criteria. After we have 2 meetings, one with expert and one with patient representative to review of draft proposed indicators. And there is discussion about the proposition and adaptation and so on. Finally, OECD sent the definitive version in English in October 2019, and PACS start the translation in French from November to January 2020. And we do the translation in French with professional and also with patient feedback. In fact, we have a focus group with professional to evaluate the translation of the key concept in French and to be sure that the meaning of the question is the same in French and in English. After, we have a patient feedback with a survey with 60 patients who assess the clarity and the comprehension of each question. The translation of the question was validated if at least 80% of patients say that the question is clear. After that, we have 5 questions with less than 80% score. And we use patient comments to adapt the traduction and the presentation of question. And after, we collect 20 other feedbacks from patients to assess the clarity and the comprehension of these 5 new question formulation, in fact. And we reached the score of 80% for these 5 questions, and we stopped the evaluation by patient at this step. After this step, we want to launch the data collection, but you know we have a big crisis in the world, the pandemic COVID-19. Due to this situation and the problem in our healthcare system, we postponed the data collection, the pilot data collection, and now we are ongoing the pilot data collection in collaboration in Belgium with health insurance organization. I will explain that just after. Yes, in fact, we have 3 health insurance organization who participate this data collection. In fact, this health insurance organization select patient in their database, patient hospitalized during the third month preceding the date of data extraction. Why they do that? We do that because we need time to exclude some patient from the database and to include them in our survey. And after that, health insurance organizations send an email with a link to the survey to their members, and the members respond to the survey. It's not, in fact, it's not an hospital survey. We don't have results from by hospital, but for all the French-speaking patients in Belgium. We have selection criteria for this survey. We select patients between 18 and 80 years old. The patient have to stay at least one night in a general hospital. We exclude psychiatric hospital. We also select French-speaking hospitals and French-speaking people in the health insurance organization database. The inpatient must still alive. It's why we wait 3 months, because the health insurance organization needs time to exclude these people from their database, and to be sure to don't send a survey to these people. We also exclude patients admitted to palliative care or nursing home after their discharge. And also the last criteria, we need the email address of the patient, and sometimes in the health insurance organization, you don't have the email of the patient, but they send the survey to all patients with an email in their database. Yeah, we are aware that we have some limitation here. We focus the survey only on people with email, and maybe we will see this on result, but we are aware about this limitation. I'm going to present now the tool we used. It's the tool developed by the OECD, and we make the translation in French. You have 4 questions assessing the communication on this tool. You have also 5 questions assessing the safety of care, 3 questions assessing the incident management, 2 questions assessing other negative experiences, and 3 questions assessing the continuity of care. For the communication, you have an example of the question asked to a patient. For example, during this hospital stay, did you feel that there was a good communication about your care and treatment between doctors, nurses, and other hospital staff? There is also a question about if you are aware of, if you are aware about the person you have to contact if you have a concern during or worries during your treatment, and so on. It's it's question about communication, in fact, in the hospital. You have specific question about the safety of care. For example, during this hospital stay, did you feel confident in the safety of your treatment and care? The second question is the more important, because it's the question who identified the incident during the hospital stay of a patient. We asked the patient if he experienced a patient safety incident during his hospital stay. After we asked with an open-ended question to the patient, we asked to describe the patient safety incident. After we asked if Um, and after we ask if if the patient report this experience to an hospital staff, and how the patient finds that he experienced patient safety incidents. After we have question about the management of incident, you can see the question. We ask if the patient feels that the incident was managed in a way he wanted. If he respond yes, he had the question 2, and no, he go to the question 3. And he can select the reason why the incident were managed in a way he wanted. And you see the modality of response. For the question 3, it's the same modality, but with the negative formulation. And the patient can choose the good this good reason. We have also another question on other negative experiences. You can see the question 1 and 2, it's the same, but if you have an incident, you have the first question, and if you don't experience an incident, you have the second one. And we ask if you are upset because of the way you were carried for or treated by hospital staff. After, you can describe this negative experience, and if you speak about this experience with a caregiver or an hospital staff. And finally, you have three important questions about the continuity of care, and you can see this question at some hospital use already this kind of question during their evaluation of patient experience. It's classical question about the continuity of care. If you understand all your medication problem or the continuity of your treatment after leaving hospital. We also collect for the analysis the other socioeconomic background to have a good view of the problematic in French-speaking population in Belgium. We collect also age, sex, highest level of education, subjective assessment of health status, province or region of residence, duration in days since the hospital discharge, and length of stay in hospital. And this variable will be important for the psychometric validation of the questionnaire in French in the next step. What are the next steps for this project? I'm going to now make the data analysis in January to March 2022. With the analysis, I would like to make a psychometric validation of the result of the traduction of the questionnaire, and after we want to make a restitution of results and make some communication about these results. And after that, we want to propose the questionnaire to healthcare organizations who want to test the questionnaire in their organization and to identify problematic and also identify improvement topics of improvement with this questionnaire. If you are interested by this questionnaire, the contact person in OECD is Rie Fujisawa. You have the address mail here. Maybe she's here in the panel. I don't know, but yes, it's the person, the contact person in OECD. If you want to to have an access to this questionnaire. I know you have a lot, or you have other traduction in Poland, Estonian. I don't remember exactly the other traduction, but you can have the questionnaire in English first, and after see if you have a traduction in your own language. Thank you for your attention. My presentation is finished. I suppose I'm in the time.
Yes, thank you, Quentin. There's no question in the chat, but I have one question, and if somebody wants to add another one. Oh, there is a question from Tela. Yeah. Take the floor, Tela. Go on.
Thank you for this presentation. It was very interesting. You know, we've done the survey in Estonia 3 times as well, but not the whole survey. We selected questions from there. But my question is actually different about PRIMs. And about I was really fascinated about the beginning of your presentation, how you introduced the topic. That was very, very interesting, and it made me think. I know I've been trying to find an app that I accidentally saw one time and never found again, for patients to be prepared for patient safety incidents, how patients themselves can attribute to patient safety in a hospital. And then I've been trying to search for it, but I haven't found it again. I know there's like Patients for Patient Safety organization in the States, for example. And my question really is, besides those hand hygiene things, do you have any other like directions or information material for patients, for example, in Belgium, or have you heard from anywhere else from Europe, where they give a concrete directions or instructions for patients how they can contribute to patient safety? Thank you.
Yeah, I'm going to start by the second question. No, I have no information about how the manager can make some effort to manage this kind of problem in their institution. We have also this data about patient, and I reveal here, but no, I don't know. And for the first question, it was how remember. I don't remember the first one.
No, there only was one.
Yes.
The first one was thank you. It was very interesting.
we just because I'm in the same country as Quentin, and patient involvement is kind of my topic. We do promote in Belgium kind of speak up campaigns or Ask Me 3 and those kind of tools that exist and are, I think, widely known. We also have other initiatives about campaigns about what matters to you. It kind of gives you an insight about what is important for patients, but it's not really specifically on patient safety issues.
Yeah.
But we do have campaigns in hospitals about patient safety. They have raising awareness campaigns. They have a lot of information and leaflets about medication errors or identity vigilance. So there's a lot of work going on, but I don't know if that's really what you were asking for. I do know you have the same initiatives in your country.
Yeah. But you have also the International Day for Patient Safety in September. I think it's the main campaign to inform also main public to the problematic of patient safety in Belgium and in the world for the moment. And you have also this kind of specific campaign, like in the hand hygiene campaign or the Eurobarometers, but it's for the Eurobarometers, it's only 1,000 people by countries, and you have it's little representative of the population, but yeah, this survey exists and we can have some information about this, and I wanted to present this information.
Mm-hmm. I maybe have one last question for you as a perspective for the future. Do you think in Belgium we will continue to work with the health insurance funds that will continue to give this link or survey to patients? Or will it only be used in the hospitals, for instance? What do you think will be the future of survey?
I think it was a good project with the health insurance organization, and we see that the data collection can be made in collaboration with this organization, because they can identify almost all patients in the countries, because we have here 3 insurance organizations, but you have 5, I remember, for French-speaking part in Belgium, and these 5 organizations, yes, have, I think, 98% of the population in their database, and yeah, we can use this this collaboration to collect data. General data on the population, because here we don't have data by hospitals, because we don't have this information. But yes, it's a good opportunity to identify specific topics when we want to survey a population or a specific population, because you can also, with this type of data, select specific, for example, specific condition or specific population.
Mm-hmm. Okay, thank you. Then I will just quickly launch a survey of this webinar. So for those who are still connected, you can evaluate this webinar. And I would like to thank Quentin for his excellent presentation. There was also some comments in the chat for your beautiful presentation. It was really interesting. Thanks for sharing. So that's a really great presentation you gave. So thank you.
Thank you.
And I will now just wish you all the best for the end of 2021. To all of you, and for the next quality and safety webinar, we'll all be in touch, and we'll be announcing the program for 2022 shortly. So thank you for connecting.
Thank you.
A nice holiday. Bye.
Bye.